Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I will be discussing internal medicine competency, congenital heart disease. Historically, many children with congenital heart disease died early, but advances in pediatric cardiology, cardiac surgery, intensive care based and catheter based interventions have dramatically changed the outcomes. Previously, more than 90% of children with congenital heart disease used to die, and they don't survive up to adulthood. So nowadays, adult congenital heart disease has become an important subspecialty, and adult physicians are increasingly seeing patients with congenital heart disease. So these are previously undiagnosed congenital defects, residual lesions after childhood surgery, late complications of repaired congenital heart disease, arrhythmias, heart failure, patients developing pulmonary arterial hypertension, and pregnancy-related cardiovascular issues in congenital heart disease. So adults with congenital heart disease constitute a rapidly growing population requiring lifelong surveillance and specialized care. And that is the importance of this topic, congenital heart disease in adults. So the learning objectives are at the end of the session, you should be able to recognize common congenital heart diseases that present at adulthood, obtain a focused history, perform structured cardiovascular examination, identify classical bedside findings, formulate differential diagnosis, and develop management strategies. And what are the indications for referral and intervention? So now look into what are the common congenital heart disease that are seen in adults. They can be one, acyanotic lesions, that is left to right shunt. Classical example is atrial septal defect, ventricular septal defect, patent ductus arteriosus, and rarely atrioventricular septal defect. Obstructive lesions are the coarctation of aorta, pulmonary stenosis, bicuspid aortic valve, subaortic stenosis, that is hypertrophic subaortic stenosis. Cyanotic lesions encountered in adults. They are repaired tetralogy of Fallot, the Eisenmenger syndrome, that is left to right shunt developing pulmonary hypertension and then becoming right to left shunt. Epstein's anomaly, congenitally corrected transposition, and fundant circulation survivals. So we have classified adults with congenital heart disease into previously undiagnosed ones. Then diagnosed ones can be acyanotic, obstructive, or cyanotic diseases. Hope this is clear to you. Now let us take a case scenario. A 29-year-old school teacher presents with progressive exertional breathlessness, palpitation, easy fatigability. There is no chest pain, no syncope. She recalls that she has been told that there was a murmur as a child. What is the diagnosis you will consider? It can be ACHD, VSD, PDA, pulmonary stenosis, bicuspid aortic valve, mitral valve prolapse. These are some of the common conditions that you will come across. So now we look into taking the history. So in the presenting complaint, just like the cardinal cardiac symptoms, you have to look for. They are the dyspnea. You have to assess, just like in any case, and assess the NYHA class also. Presence of palpitation suggests atrial fibrillation, development of atrial flutter, and also supraventricular tachycardias. These are common in atrial septal defect. Remember, atrial septal defect predisposes to development of atrial fibrillation. Patient can develop exercise intolerance with the development of pulmonary hypertension or development of heart failure. So ask about questions like climbing stairs, walking uphill, etc. And specifically ask about cyanosis. When did your lips or fingers become blue? So the cyanosis indicates either a cyanotic congenital heart disease, if it was present earlier, or later development indicates it is a development of an Eisenmenger syndrome. Syncope is very common. This may indicate severe aortic stenosis, pulmonary hypertension, development of arrhythmias. Patient can present with a stroke, and in such conditions, stroke or TIA, remember PFO, persistent foramen ovale, receptor defect, paradoxical embolism. And the migraine history should be looked for because the patent foramen ovale PFO is common in patients with migraine. Think about that. The past history asked about childhood murmurs, detected to have murmurs at childhood, previous surgeries, catheter interventions, heart failure admissions, history of endocarditis, and arrhythmias. Family history is important because you should ask for congenital heart disease in the family, sudden cardiac death. This is especially in subaortic stenosis or hypertrophic cardiomyopathy. History of Marfan syndrome, again, or bicuspid valve, all these can think about the presence in the family. So now you go for a general examination, look specifically for cyanosis. Identify whether it is central cyanosis or peripheral cyanosis. Clubbing indicates chronic hypoxemia. Look for syndromic features. Presence of Down syndrome features such as AV septal defects. Turner syndrome, remember coarctation. In Marfan syndrome, aortic dissection. Pulse, carefully assess the rate, rhythm, volume, especially radiofemoral delay, which is characteristically seen in coarctation of aorta. Blood pressure should be measured in both arms and in one leg if coarctation is suspected. Cardiovascular system examination, look for precordial bulge because some people with congenital heart disease can have precordial bulge because the bony cage was moldable at the childhood when the heart was enlarging. Look for surgical scars, visible pulsations, especially in patients with coarctation. Look at the back. Palpate the apex speed, position and character. Look for parasternal heave, which suggests right ventricular enlargement. Thrills indicate significant murmurs. Auscultation is key. Atrial septal defect, fixed wide split, and pulmonary murmur, systolic murmur. In VSD, you get a harsh pansystolic murmur initially. The PDA, continuous machinery murmur. Before development by pulmonary hypertension. In pulmonary stenosis, look for ejection click, systolic murmur. Coarctation, auscultate the back for murmur. Look for radiofemoral delay. So in our patient on examination, if there was fixed splitting, there is a pulmonary ejection systolic murmur and right ventricular heave, the most likely diagnosis is ASD. What are the investigations? You look for ECG. ECG shows in ASD shows incomplete RBB, that is RSR pattern in B1 and right axis deviation. RBB with the left axis deviation suggestive of ostium primum defect. Remember these two ECG findings. So we go to the chest X-ray. Chest X-ray usually shows cardiomegaly in ASD. There will be pulmonary plethora. Enlarged pulmonary artery is an important finding. Echo is the gold standard. Provides anatomical diagnosis, the shunt size, valve function, and pulmonary pressures. Additionally, you may require transesophageal echocardiography, CT angiography, or catheterization. So in adult congenital heart disease, you go for history and examination, ECG, chest X-ray, echocardiography, and then assess symptoms and think about further management. So we'll a few words on the lesion specific management. In atrial septal defect, indications for closure, symptomatic patient, definitely, and right heart enlargement, significant left to right shunt as an indication for surgery. Catheter based closure, first line for second defect. Advantages are there is no stenotomy, short hospital stay, rapid recovery. Surgical closure for large defects and unsuitable anatomy. In PF4, usually asymptomatic, consider closure if cryptogenic strokes are occurring or recurrent paradoxical embolism. In ventricular septal defect, small VSD, observation, large VSD, surgical repair, device-based closure in selected cases. PDA, again closure, coil occlusion, surgical ligation if required. Coagulation of aorta, again the management depends upon the clinical clues like hypertension, radiofemoral delay, rib notching. Treatment is balloon angioplasty, stent implantation and surgical repair. In bicuspid aortic valve, the complications are the patient can develop aortic stenosis, aortic regurgitation. Management is surveillance, if required valve replacement. In pulmonary stenosis, mild, just observation, moderate, severe, you may go for balloon valvotomy. Medical therapies also. Tetralogy of Fallot in adults, development of pulmonary regurgitation, RV dysfunction, arrhythmias can occur. Again, the treatment is depending upon the clinical scenario. Many repaired tetralogy of Fallot patients require replacement of pulmonary valve. Yes, Eisenmenger syndrome, should always remember. Long-standing left to right shunt, that is ACHD, VSD, PDA, eventually produce irreversible pulmonary vascular disease, resulting in shunt reversal. That is the Eisenmenger syndrome. VSD developing Eisenmenger is the Eisenmenger's disease. Management, avoid closure of the defect. You may give pulmonary vasodilators, oxygen inappropriate, specialized care. Complications of adult congenital heart disease, arrhythmias, heart failure, pulmonary hypertension, infective endocarditis, stroke, sudden death, and complications during pregnancy. So how will you present? You can present like this. This is a 29-year-old woman presenting with progressive exertional dyspnea and palpitations. She has history of childhood cardiac murmur. Examination reveals right ventricular heave, fixed splitting of the second heart sound, and pulmonary systolic murmur. ECG demonstrates complete right ventral branch block. Echocardiography confirms secondum atrial defect with right ventricular volume overload. The patient is a candidate for transcatheter device closure. This is one way of short presentation. So the clinical pairs are fixed split, remember ASD, unless proved otherwise. Continuous machine murmur, PDA. Again, remember with development of pulmonary hypertension, the continuous murmur may disappear. Radiofemoral delay always look for, and sometimes comes with hypertension and coaptation. Harsh systolic murmur, BSD. BSD when become Eisenmenger, the murmur may come down with the development of PAH. The shunt may get reversed as the Eisenmenger syndrome, and there may not be much murmur. The only finding will be patient will have cyanosis with the clubbing, which is a pulmonary hypertension and a single second sound. So cyanosis with the clubbing is Eisenmenger syndrome. So take home message. Adult congenital heart disease is increasingly becoming common. ASD is the most frequent congenital lesion diagnosed in adulthood. Any elderly coming with atrial fibrillation, if it's a congenital heart disease, think about ASD. Echo is a cornerstone of investigation. Many lesions can be treated percutaneously. Lifelong follow-up is essential. Pulmonary hypertension must be excluded before defect closure, and many patients require structured surveillance, and because the patient can develop complications.